All right, let's get started. I see 10:02. We've got about 80 folks on the line. It's wonderful to see all of you. Welcome to the February Medic Collaborative-wide meeting. Of course, I'm Keith Coker, one of the medical directors. It's great to see everybody. I'm going to spend a little bit of time here, of course, just going through some initial announcements and some housekeeping, providing some overview of the agenda, and then we'll get into the bulk of the meeting. As always, we got to list some disclosures. I've got a couple related to some outside funding that's tied to some of our medic work. The rest of the coordinating center doesn't have anything to disclose. Okay, so here's our agenda. We've got a 2-hour meeting today. The last half will be an external speaker. We're really excited about Todd Florin. He's gonna be talking about his experience and expertise related to how we think about testing using chest x-rays, I think in particular for pneumonia. And that's gonna be one of the themes of today, thinking about our thread around All In for Kids in 2023, circling back to some of the topics that we brought up with the pediatric surge, even doing some small group breakout sessions as part of that too. But we'll start in the beginning, just recapping from the 2022 year and talking about some of our performance from then. Okay, so a few things, as always, about etiquette on Zoom. Make sure you mute when you're not talking, so we exclude background noise. Please also, if you can, turn on your video. That just helps, of course, with the experience of the meeting. One other thing too, just to help everybody, if you can change your name and add your site, so we have some context as well about who you are. And then please use the chat function. This is the kind of meeting where that's going to be really useful, and it's a nice way to join in the meeting as well. And we'll rely on that in particular too with the external speaker that we've got later. Okay, so as a reminder, we have CME here. Similar to every other time that we have a meeting, scan that QR code to get your CME credit. Okay. We do want to pause here. You know, I think speaking for myself, the coordinating center, you know, we just didn't feel like it was right not to acknowledge the events that happened just, you know, less than 2 weeks ago at Michigan State, where 3 students were killed and 5 were injured related to gun violence. You know, I don't necessarily have much really to add to what others have likely said, except to simply point out that, you know, we are a network of emergency departments and we are the safety net. And, you know, in this moment and on that day, it happened to be one of our partner hospitals in Lansing, Sparrow, you know, that was on duty for that moment. You know, I did want to give the team from Sparrow a moment to say a few words if they'd like. So anybody from the Sparrow team, you're welcome to unmute and say a few things if you want.
Hi, Keith. Yeah, this is Pamela Emanuel.
Hey, Pam. Yeah.
Yeah, thanks for the acknowledgement here. Certainly a difficult time for the Sparrow community. We were really, I mean, Sparrow, but also Lansing in general. The state overall really responded to this, and that was so appreciated. It was really such a difficult situation, but really appreciate all the support that we got all around, not just fellow physicians, but just around the state, EMS. It was really incredible, the teamwork that really came together in such a tragic incident. So appreciate you taking the time to acknowledge.
Absolutely. And of course, we appreciate you being there. Certainly, I see a chat message there about, you know, supporting all too. So thanks for saying a few words. Okay. So let's move into the rest of the announcements. We have supported a training session for those getting experience using medications for opioid use disorder, basically buprenorphine. We've done this in the past in partnership with another project. We're having another training session coming up in March. There's a $500 incentive payment from Blue Cross available to those who participate. And it's open to certainly physicians, but also APPs and even residents. The training's excellent. I've been to a number of these over the last couple of years. It's taught by emergency physicians. And really, you learn how to use buprenorphine at the end of the day going through that training. Okay, another announcement too on the same kind of topic. This group is sponsoring a research project where they want to do some qualitative interviews for folks that are in emergency departments and their experience with naloxone. There's a $200 incentive for signing up for this. So please consider it. If you've had some experience with naloxone in your own shop, just scan that QR code to sign up. Oh, another sad moment for us from the Courting Center team is we have to say goodbye to such a treasured staff member, Allison Stone, who's the original data manager for the Courting Center, overseeing the registry, who's moving on to another chapter of her life in a couple weeks. Allison has probably like touched every single data element in the actual registry at the end of the day. We're going to be sad to see her go. So please feel free to say your goodbyes to Allison over the next couple weeks. Okay, we also want to introduce a new individual to Medic in the larger audience here. So let me set this up a little bit. So every CQI has a medical liaison stationed within the Value Partnerships office. And we have a new one here, Banesh Patel, who what is great about is actually an ER doc, Michigander, trained in the state. And this is the first time we've got an emergency physician as our medical liaison, which I'm really excited about. We're all excited about. So just want to give him a couple minutes to introduce himself. I actually didn't scan to see if Banesh is on the line. Okay, awesome. Banesh, the floor is yours. Yeah.
Thank you, Keith. Yes, and I did train in emergency medicine here in Detroit, and went into hospital leadership about a little over 10 years ago, and decided to make the change to come over to Blue Cross Blue Shield of Michigan in September, really overseeing quality and affordability, which I have a passion for. But I'm actually excited to be part of this. During my time in Detroit, Medic was just getting started, and so I didn't get the opportunity to participate like how all of you have been able to do. And so now I get to be sort of on the outside and get to see all the great work that I know we are capable of doing in emergency medicine. We touch such a broad population, mostly at their most vulnerable, and whatever we can do to continuously improve the care that we deliver is always going to be first and foremost. So happy to be here and just sitting on the sidelines and watching and cheering everyone on.
Thanks, Banesh. Awesome. And certainly on behalf of everyone here, welcome to the party, and we look forward to the partnership.
Thanks.
Okay, so we're going to spend the next few minutes here recapping work from 2022. The February meeting is a natural moment to spotlight what we did in 2022 and reinforce some of the things that we've accomplished. Here's our standard table. Just really provides a high level understanding of the quality initiatives that we've been part of and some of the performance changes over time. You know, there's some nuances here that aren't fully explanatory about how these things are going because some sites are leaving and joining at various points. But generally speaking, you can see performance improvement over time along our metrics. And then this is a slide that we've been doing now. This is the second year, just to provide an infographic explaining our work and the value that we think that we provide within the quality improvement efforts. And our, you know, it's got some assumptions and limitations in how we do these calculations, but generally shows the quality improvement impact that we've had as measured by avoided tests and avoided spending. And if you add up all those totals at the bottom, we're talking about an estimate over $60 million avoided spending over the years that Medic has been in the business. So it's just great to see this, and it's really a testament to all of your efforts locally in this work. Okay, so let's just recap again on some of the performance incentives that we are tied into with Blue Cross. All this is going to be success that we're going to be reporting here. So this is for P4P. This is the hospital side. We also call the performance index at times. We had 2 group-wide measures for that, or collaborative-wide measures as part of that P4P points assigned. One for adult head injury, one for pediatric head injury. And the bottom line is we made those targets in 2022. So all those points were achieved. This is what it looks like month over month for 2022 for adult head injury, where you can see the green is the target. And then the next slide is the similar one for peds head injury, where the green is the target for that. So success there. The other thing that we wanted to show is the distribution of those P4P scores assigned to each hospital. We do this annually. It's a 0 to 100 point scale. This is the report that we sign off on and give to Blue Cross, and that determines their incentive payments to the hospital. This is the 2021 distribution. Each block is a hospital. And here's the 2022 distribution. So similar average, but I think it's clustering at the higher end now for individual hospitals. And we think this is, you know, a demonstration of good work, of course, on all of your efforts in 2022. One point of emphasis that we just want to note here is sometimes we get questions about, you know, why are there points assigned within this performance index to data transfer and accuracy and timeliness. And the reason is because, you know, this is essential to the kind of work that we need to do in providing timely audit and feedback reports, timely measurement. And there's, you know, time and energy involved if we're not getting data in timely ways. So I think it's just a point of emphasis that we want to continue to be able to assign points here. And that's just important to do your best to get us timely and accurate data. Okay, switching now to VBR, value-based reimbursement. So this is on the physician side. These are the incentive programs tied to provider physician billing. We have a collaborative-wide VBR. This provides a 3% fee schedule increase on commercial claims from Blue Cross. There's a measurement period in 2022, and then it gets paid out in 2023. And it's not for all Medic sites. You have to be in it for at least a year of data before we can enroll you. But for those that were in this program, the bottom line is we attained our targets. So you will get that 3% uplift in 2023. One was for the adult head injury measure. You can again see the month over month target here. And then the next one is the pediatric head injury one, where again, you can see that we're in that green zone. Okay, so I'm going to hand things over to Andy for the next 2 slides here.
Great, thanks, Keith. So just wanted to go over our individual physician VBR, a couple of slides about that. So just as a recap, in 2021 was the first year that we did this individual physician VBR. And last year we had 351 physicians participated at 18 sites, and you only had to participate last year. There was no performance target. So in 2022, we added in you had to meet one of our head injury targets, and similar number of physicians participated, and excited to see that 293 out of the 320 that participated actually met one of the targets. That's over 90%. So that was great to see. And one quick reminder on this that's down at the bottom of the slide there, that please remember that if you're participating in this incentive, to make sure that you're enrolled in one of the PGIP POs, because that is the method to get paid. And if you're not enrolled in that, you will not get paid. So moving on to 2023, just a quick reminder. In this year, each site had to choose 2 out of 4 measures to work on. Most sites have, I don't think everyone has actually let me know about that. I need to follow up on that. This is different than the P4P selections that you made, so I will follow up if anyone hasn't, but very similar to last year, you're working towards meeting one of the 2 performance measures, need to have an account on Tableau, and you need to meet the performance target and fill out a survey at the end of the year. Another VBR that we're working on is the 2% smoking cessation VBR. This is 100% optional, so your site can choose to do this or not, totally up to you. We did in 2022, we had 13 hospitals participate, so 177 physicians were able to qualify for the 2% fee schedule increase, and these are all additive. So if you got you can get 3% for the collaborative wide, 2% for the individual physician, and 2% for the smoking. So you could get up to 107% fee schedule. In 2023, there is a performance requirement to meet. It's not too late to do that. Your hospital has to do it or not. Again, optional. So if you're interested in participating in 2023, there's still time, but time's getting short. So reach out to me or Katie as quickly as possible, and we can get you set up on that. And one other thing to kind of go over really quick is that due to some of the changing in deadlines with Blue Cross, we are changing the measurement period for VBR in 2023. I will send out a detailed email with some, hopefully good explanatory things about this. But long story short is that for the performance, instead of the normal 12 months, which usually ran from November to October, it's only going to be 10 months, running from November of 22 through August of 23. For the collaborative-wide and the individual performance. For the smoking one, which doesn't require any abstraction, we can let that run 1 more month, but we need to submit all of our finalized data by December 1st to Blue Cross. So we had to change these measurement periods a little bit. But the timeline to do the survey will not change. But I will, again, I get a million questions on this, and I'll definitely put together some communication to go out via email to explain all that, but just wanted to kind of get it out there. Okay, last thing for me, we're doing something new this year. Hopefully it will be well received, giving out some annual medic performance awards. Two different ways we're doing it. For individual physicians, top 10 performers on each initiative, and the site level, we're doing the top performing site and the most improved site for each year. I have some notes in here. I'm not going to go too deep into it about the methodology. It got a little hard because we didn't want to say someone who has 0 out of 1 necessarily is the the top performer in the state. So we did set some volume criteria, and the pediatric measures, we split it out into 2 ways. So there's a top performer at mixed population sites and top performers at pediatric only sites. So I will hand that back over to Keith, and he can go through who the winners are for the 2022 year.
Yeah, thanks, Andy. I mean, so I look at this and I'm just like flabbergasted by some of these metrics that we're seeing here. So these are the top 10 emergency physicians in the entire state within the MEDIC network. We're talking about 500 to 600 ER docs that are in our registry. This is like the top 1%ers. On the left side of the screen, you see the measure for diagnostic yield for pulmonary embolism CT scanning. And on the right side, you see the appropriateness use for CT scans for adult minor head injury. At the bottom of the tables, you can see the denominator cases. So again, going back to Andy, just setting a baseline threshold for a large enough sample size that these are meaningful. And it's pretty incredible to me, like those diagnostic yield numbers, those appropriateness numbers. The folks that we've highlighted in bold are clinical champions and partners within MEDIC, just to sort of call them out very directly. As folks that are clearly, walking the walk of quality improvement. And again, just want to recognize these top performers. And we've got a few ways that we're going to be doing that as well, not just highlighting them here on the meeting. So Michelle, I think you're next. We're going to talk through the PED stuff.
Yeah, thanks, Keith. So on the individual physician awards for the pediatric CT for minor head injury in the mixed sites, we kind of split these out to the mixed sites versus the pediatric sites to just give you a sense of this. And again, as Keith pointed out, the performance is amazing. Really doing good work in all of these sites. And you can see they're pretty well distributed around the state in the mixed sites. And the range of the denominators are at the bottom again. Similarly, for the CT for PEDS minor head injury among the PEDS sites, look at those numbers. So many are 0%. It's just amazing that they are really champions of this metric. Next slide, please. And so for our chest x-ray measure, again, split between mixed and PEDS sites, have a lot of mixed sites who are just doing extraordinarily well on pediatric measures for quality. So I want to call those out around the state, as well as our PED sites. And again, the clinical champions are bolded. A nod to Helen DeVos, who's basically an amazing site for this particular measure, as all of the top 10 physicians at that site are performing amazing. So you are a leader. I'm sure people on this call are going to take a look at this and say, I want to have what you're having for breakfast. So next slide, please. So we also wanted to give awards, literally 30,000 foot site level awards. These are the top performing sites in MEDIC on each of our measures. And you can see Munson is it for CT for PE in adults. Corewell, now what is now Corewell Health, several sites are performing at the top of these measures. CT for minor head injury for in adults at Blodgett, Kelsey for minor head injury and CT for kids, Helen DeVos for the chest x-ray again, and asthma time to steroid at Zealand, and University of Michigan West at the safe discharge for lower chest pain. Awesome work, everybody. It's just amazing with your levels. Next slide. And then we also wanted to recognize, because we can't all be the top, but there are just huge improvements being done. And we wanted to really pay attention to that, because there are movers and shakers coming up the ladder, particularly for each measure. I'm going to call out Munson Healthcare and two of these measures, CT for PE in adults and safe discharge for chest pain. Again, Corewell, Butterworth, and Kelsey, and then Henry Ford, Wyandotte, and Sparrow. So, despite the fact that we are incredibly busy, these people are really driving change in their prospective site. Thanks. Next slide. So we're going to stop here real quick, just see if there's a question, raise your hand or put something in the chat if you want us to just say or bring anything. Just some yays from Corewell and Lee Benjamin at Trinity. Okay, in the interest of time, we're going to push forward. We're going to just talk and revisit the pediatric surge response follow-up. Back in November, we had a town hall really quick. Remember, we had COVID, we had town halls, now we had PED surge. So it's turning out that our platform is an incredible, valuable measure or method for getting us together, discuss, and share things very quickly. So the takeaways from that meeting were literally opportunities for an interest in just-in-time for training and telemedicine. Remember, this isn't, we feel like we're getting good at this now. It's not a matter of if, it's when the next thing's coming down the pipe. So We get on a call and we fix things pretty quick. We revisited National Pediatric Resident Readiness Toolkits and checklists. We put those on our website. If you haven't taken a look at them, please do so. They're well vetted and stood the test of time. There were challenges, numerous, all around the board, transferring patients to children's hospitals accepting them, holding on to patients in referring centers, with just-in-time training being necessary, and certainly in the milieu of staff shortages, space constraints, and equipment problems, because a lot of sites were not used to having equipment and special things necessary to take for kids. So shout out for all of those who fixed and found ways to do exactly all those solutions. So I'm going to leave it to Katie, just so you can get a little sense of what happened in our data registry during that time period.
Thanks, Michelle. So some of you guys have seen these slides before, some of you haven't. Again, in the interest of time, I'm going to go through these relatively quickly, but these will be shared, and feel free to follow up with questions afterwards. So this is just kind of showing you the pediatric surge volume numbers that we have and kind of how that related to our chest X-ray utilization measure. I think our initial concern was that with this pediatric surge, strain on resources, we would see a hit to our chest X-ray utilization overall. And the great news that I would love to share is that we actually saw the opposite. We actually saw improved chest X-ray utilization rates. Just the top line for reference is all pediatric visits, because again, when we're thinking about our chest X-ray utilization measure, we know that that's only asthma, bronchiolitis, and croup patients, and we saw an increase in all types of respiratory visits, not just those 3 diagnoses. That correlates obviously with our increased denominator. So higher, or red equals higher volumes in those 2 rows. Utilization, again, green is the lowest performance that we've had. I think the one thing, the last time we showed these numbers, we did not have November volumes. So that is new here. Obviously we see November was even busier than October. And actually for our mixed population sites in particular, I want to give you guys a shout out, because you had the best chest X-ray utilization we've ever had within Medic. And this site is in this graph here, or these numbers are including everybody in our collaborative who had a full year of data. And the other thing that I want to point out here, when we look at our previous, we're kind of comparing these numbers from this surge to previous surges that we've seen in our Medic collaborative. This is a smaller subset of Medic sites who've had data consistently back through January of 2019, but we have seen surges like this previously. And then kind of similarly, we don't want to see spikes or red in the chest X-ray utilization rows there, and we don't. I think, again, kind of similarly, we've seen stable, at least stable chest X-ray utilization in those months of very, very high visits. So I just want to give everybody a shout out for the incredibly amazing work that you've done when we know that there was a crazy strain on resources at our peds hospitals. We know you were getting transfer requests and boarding, and pediatric hospitals actually, for the first time ever in November, in our collaborative, saw an aggregated higher number of pediatric cases than our pediatric sites aggregated. So well done, everybody. And again, these numbers will be shared in the slides, and please reach out with questions.
So I just want to round out and close, just to share some preliminarily the interventions that happened during that time period, because we know it's going to happen again, and we want to make sure that we get these kinds of interventions shared with everybody else, so that regardless if it's pediatric or not pediatric, we're going to have something else that comes down the pipe. So what did we do, and how have we hardwired these in our systems? How has your site changed? And what have you done to get your at your institutional level to do things so that as these things come, we can see them in advance and change? And how can we help you? So I just want to call out a big shout out for Trinity Health. They had difficulty transferring kids and no inpatient beds, and figured out some ways around that. Wyandotte had collaborated with CHOM. Folks came down, went over their policies and procedures and guidelines for how to care for people and how to move people around. Trinity at Chelsea, again, transferring critically ill children and trying to get reviewing, there's a pediatric readiness checklist. Where is that? How can we get those things? And they got them. ECS, amazing, huge hospital group, challenges, accepting transfers, getting at the elbow support for their EDs and flexing spaces around. That happened at a lot of different centers. And CHOM, same thing, staffing models with ED physicians now, moving away from the you know, he can't put a patient in a room without a nurse. It's, you know, nope. Now doctors are buying, you know, time with themselves to just try to move people through systems and rounding by other specialties and patients that they're sitting on, both surgery, ambulatory care doctors, rounding on patients that are existing in the ED space. So a lot of really great things we can all learn from them. So shout out to all of you. So we're going to jump right in here for our theme this year is All In for Kids, and we're going to review our progress, and we're going to jump right into breakout sessions. So I'm really so excited to tell you about this trend. The pediatric intermediate risk minor head injury, I'm just going to give you a year just sort of broad 30,000 foot view of where we're at. You can see some downward trends, but sort of a little bit of a plateau happening there, and the pediatric chest X-ray utilization nicely flowing downward over the years. So we need and still can improve, and I'm going to let Katie take a little bit more of a granular way in which we could do that. Take it away, Katie.
Sure. So we know that chest X-ray utilization and our pediatric intermediate risk head injury utilization measures can be particularly challenging for QI, right? They're not quite as straightforward in terms of finding opportunities for improvement as, say, our adult head injury appropriateness measure or our safe discharge chest pain measure. So what we're doing is trying to find some opportunity within this larger bucket of patients, right? Where we're not telling you something is necessarily wrong, right? When we're looking at pediatric head injury, PCARN recommends observation versus CT for these patients. Again, chest X-ray, we know that some of these kids will likely benefit from chest X-rays. We just need to find the population within these bigger bucket of patients where we do have opportunities for improvement. And with each of these measures, we've identified areas which we're hoping to share with you all that you can kind of take back to your shop and maybe use that. So for CT, we'll start with the intermediate risk minor head injury. ECS talked about this a little bit actually at our previous collaborative wide meeting with patients, particularly with isolated intermediate risk symptoms. So for example, a patient that comes in, their only intermediate risk symptom is vomiting. PCARN knows that those patients are typically not at higher risk of the traumatic brain injuries, and those kids more than likely can be safely obsed. So we can help within our registry identify those patients, right, that have isolated symptoms and still received a head CT. So maybe those are some opportunities for us to learn something rather than looking at the kids that have multiple symptoms, may or may not need a head CT. Like this is just something that we can focus on in terms of opportunity for improvement. Similarly for chest X-ray, we have our low value chest X-ray guidelines that we actually just updated based on the new Choosing Wisely guidelines published by the American Academy of Pediatrics. Again, we're not saying that patients with these things necessarily need a chest X-ray, but we feel pretty confident saying that patients without any of these things probably do not need a chest X-ray. So rather than focusing on the entire bucket of patients that receive chest X-rays, let's find that smaller group of patients that we feel pretty confident we can improve on. And again, that's that bucket of patients that didn't have any of these things and still received a chest X-ray. So those are two things that we're working on. We're hoping to if you have questions on those, please feel free to reach out. We've worked with sites previously in identifying those cases for them. And I think that that's helped a few of them improve. We are working on some Tableau dashboards. Shout out to Dr. Fong, who's been working really hard on building these. This is a screenshot of a respiratory dashboard that's going to be live very soon for you guys. You'll be able to call out your lowest risk patients here, the chest X-ray utilization, the patients that received chest X-rays without any of those higher risk features relatively easily. And then if you move to the next slide, actually, we also will have this amazing these comparison statistics that you can review as well, which again, we have these available in our other reports, but the piece that's new here is the ability to compare your performance at your site to the rest of the collaborative within each of these buckets, right? So you can look at your chest X-ray utilization, for example, in different age groups compared to the rest of the group and the different diagnoses. The ability to look at different time frames and different dispositions. And then again, compare your performance to the rest of the collaborative and see if you can find those nuggets and opportunities for improvement. So we're really excited to share these with you soon. We're going to be building a similar dashboard for the pediatric head injury utilization as well. Again, calling out specifically those kids with isolated symptoms where hopefully we can find some opportunities for improvement on these two measures in particular while we're focusing on them for our All In for Kids year.